Hello everyone, this is Dr. Karthik AR. Today I will be discussing an original article published in the January 2025 edition of Indian Journal of Anaesthesia. The title of the study is Effect of Different Regional Anesthesia Techniques on Postoperative Analgesia Following Percutaneous Nephrolithotomy, a systematic review and network meta-analysis published from China. Introduction. Percutaneous nephrolithotomy has recently become the gold standard for treating patients with large and complex renal calculi. Despite being less invasive, PCNL patients often experience significant postoperative pain and discomfort at the nephrostomy tract. This pain can prolong the average hospital stay, and aggressive opioid use for pain management can lead to respiratory depression, nausea, and vomiting. Interfacial nerve block techniques such as the erector spinae plane block, paravertebral block, intercostal nerve block, and quadratus lumborum block are alternative techniques gaining popularity due to their capacity to selectively blockade targeted nerves while minimizing the risk of puncturing adjacent structures. However, it remains unclear which of these regional anesthesia techniques is most effective for reducing postoperative pain and side effects. Therefore, they conducted a Bayesian network meta-analysis to compare the effects of PVB, ESPB, QLB, and intercostal nerve block and local anesthesia infiltration on postoperative analgesia following PCNL with direct and indirect data evidence. Methods. The authors searched PubMed, ScienceDirect, clinicaltrials.gov, Medline, Web of Science, Ovid, and Embase to identify all relevant randomized controlled trials published up to January 2024. The study was registered with Prospero and reported in accordance with the preferred reporting items for systematic reviews and meta-analysis PRISMA guidelines. The participants or patients were those patients receiving PCNL as a treatment. Intervention was various regional anesthesia techniques, QLB, PVB, ESP block, intercostal nerve block, and LA infiltration. The controller comparison was placebo or any regional anesthesia technique. Primary outcomes consisted of the 24-hour cumulative opioid consumption in morphine equivalence and the time to first use of consumption analgesia. Secondary outcomes encompassed pain scores at 2, 6, 12, and 24 hours postoperatively, as well as occurrences of postoperative nausea and vomiting. The study design, they included all randomized controlled trials. Eligibility and exclusion criteria. The inclusion criteria were studies which had patients undergoing PCNL with an ASA class of 1 to 3, use of one of these interventions, ESP block, paravertebral block, intercostal block, QLB, or infiltration. Studies reporting at least one of these outcome measures, 24 hours cumulative opioid consumption, postoperative pain scores, time to first use of consumption analgesia, adverse reactions like nausea and vomiting, and hospital length of stay. And randomized controlled trials were included. Exclusion criteria, patients with hepatic or renal dysfunction, sepsis, psychological disorders, coagulation disorders, a history of chronic analgesic use, morbid obesity, or allergy to LA agents, reviews, case reports, observational investigations, correspondences, and/or laboratory animal experiments were excluded. So, identification of studies via database and registers was done. 225 number were identified. Duplicate records were 75, which were removed, and 153 records were screened, and 74 records were excluded because less common local anesthetics were used in 25. Required data was not reported in 40, and they were not peer-reviewed publications in 9. And reports sought for retrieval were in 79 studies. Reports assessed for eligibility were 79, and reports excluded where study design was not RCT in 13. Results could not be interpreted in 27, and intervention differences were present in 12. So in total, studies included in the review were 27. This shows the network geometry. The networks consisted of RCTs evaluating the effects of various regional anesthesia techniques on postoperative analgesia following PCNL. Each comparator, regardless of its activation status, resulted in creation of a node, while the size of the node is proportional to the number of studies in each. Now you can see here network plot of all 7 outcomes, A, B, C, like that. So A is for the outcome of 24-hour cumulative opioid consumption. B is for the outcome of time to first use of opioid medication postoperatively, and so on. So direct comparisons between interventions were visually represented as lines connecting these nodes. The thickness of the connection line revealed the volume of direct comparisons. Statistics. The analysis was conducted using R version 4 with R packages iGraph, GemTC, and Metaphor. Network meta-analysis was conducted using the Bayesian method, establishing a connected network of direct comparisons involving 3 or more interventions. The node splitting method was used to evaluate the inconsistency of the model by separating evidence on a particular comparison into direct and indirect evidence, while p less than 0.05 was considered significant. Global heterogeneity was evaluated with an I-squared statistic. The rank of the different interventions of each outcome was calculated by surface under the cumulative ranking curve, SUCRA, using the SUCRA function in the GemTC package. The certainty and quality of evidence for each outcome were assessed using the grade system. The presence of publication bias was evaluated using comparison-adjusted funnel plots and the Eggers test. This figure shows the Cochrane collaborations tool for evaluating the evidence synthesis risk of bias. The colors represent different categories: red for high bias, yellow for unclear risk of bias, and green for low risk of bias. You can see that most of it comes in the green with some in the yellow category. This table shows the grade quality of evidence assessment for all outcomes of meta-analysis. The p-values are shown here, and most of the evidence is of moderate quality to low quality. This table shows the meta-regression of primary outcomes, which were the 24 hours opioid consumption and the first time for opioid medication. And the variables were dose of local anesthetic, type of local anesthetic, concentration of local anesthetic, timing of intervention, and overall results. Discussion. ESP block is a statistically effective treatment for analgesia following PCNL compared to placebo. Paravertebral block exhibited similar analgesic effects. Furthermore, QLB performed excellently, significantly reducing postoperative pain scores and 24-hour cumulative opioid consumption compared to placebo. In contrast, intercostal nerve block and local anesthesia infiltration were inferior to ESP, paravertebral, and QLB blocks, based on network meta-analysis. Two recent meta-analyses of RCTs on ESP block for PCNL reached similar conclusions, demonstrating that ESPB effectively decreased pain scores at different time intervals and reduced opioid consumption within 24 hours. Paravertebral block is another significant analgesic method for postoperative PCNL. Our study showed that paravertebral block was comparable to ESP regarding postoperative analgesia and side effects, except for the time to first use of consumption analgesia. In addition, their findings revealed that ESP was more efficacious than paravertebral in terms of time to first use of consumption analgesia compared to placebo. Although this conclusion is based on a single outcome, ESP blocks greater distance from major vessels and the pleura reduce the risk of hematoma and pneumothorax compared to paravertebral block. So they recommend ESP block for postoperative analgesia after PCNL over paravertebral block. The study also showed that QLB performed excellently in reducing postoperative pain scores and 24 hours cumulative opioid consumption compared to placebo. QLB is postulated to induce both visceral and somatic analgesia through the potential diffusion of local anesthesia into the thoracolumbar paravertebral spaces. Therefore, they agree that QLB could be a viable alternative for postoperative analgesia after PCNL. Based on their results, intercostal nerve block and infiltration appear inferior to ESP, paravertebral, and QLB, as no outcomes showed statistical differences compared to placebo. The anesthesia provided by intercostal nerve block and infiltration is restricted to the lateral cutaneous branches of the intercostal nerve. The innervation of the deeper abdominal viscera relies on the celiac plexus. Therefore, somatic blocks such as the intercostal nerve block and infiltration might not be effective for non-somatic visceral abdominal pain. Strengths and limitations of the study. Specific outcomes exhibited a high degree of heterogeneity, which can be attributed to variations in block techniques such as variances in local anesthesia agents, concentrations, doses, and timing of intervention. The results showed significant differences in LA concerning the time to the first use of opioid medication postoperatively, indicating that different types of local anesthesias may influence this outcome. However, in terms of 24 hours cumulative opioid consumption, no significant differences were observed across these variables. Furthermore, it should be noted that not all studies included in the analysis provided data on postoperative nausea, vomiting, as well as opioid-related adverse events, which are likely to be underreported. The determination of whether analgesic interventions offer clinically significant benefits beyond pain scores and opioid consumption is essential for the inclusion of these patient-centered outcomes in future trials and meta-analysis. The contextualized framework we employed, although allowed us to meticulously incorporate clinical context into their findings, rather than solely relying on statistical significance. So to conclude, their findings demonstrated that ESP block, paravertebral block, and QLB block have certain advantages in analgesic effect for PCNL compared to placebo, with no significant ranking among them. Due to the lack of robust evidence, intercostal nerve block and local anesthesia infiltration were less effective than placebo. Further research is imperative to elucidate their roles before they can be recommended. Thank you.